Welcome to today's virtual panel discussion. I am Ricardo Rivera, your host from the American College of Healthcare Executives National Office. Before we get started, I'd like to go over a few items. For the purposes of noise control, your lines will be muted for the duration of the session, unless there is an active discussion, at which point you may unmute yourself to talk. You will also have the opportunity to submit questions throughout the discussion through the chat panel, so please feel free to submit your questions as needed during the discussion. Today's session is worth 1.5 hours of face-to-face education credit. Credit will be applied to your ACHE accounts approximately 2 weeks following the end of the session based on your attendance and completion of the evaluation. To ensure your credit is applied, please be sure you are using the Zoom platform on a computer or the Zoom app on your smartphone. Also, be sure the name you use for the Zoom session matches the name of your registration. This session is being recorded and will be available within 48 hours by navigating to your My ACHE account and selecting My Online Learning from the Helpful Links section on the right side of the screen. Now I'd like to turn the meeting over to Angela Hendry, FACHE, who will do our introductory remark announcements and introduce our moderator. Angela is the Vice President of M3 Executive Search and the Chair of GAHE's Program Committee. Angela, I'll turn it over to you.
Thank you, and good afternoon, everyone. Thank you all for being here. It is my honor to welcome you to today's virtual meeting of the Georgia Association of Healthcare Executives. Thank you to ACHE for allowing us to use its learning management system so that we can provide you all with virtual face-to-face credits. As mentioned, I am Angela Henry and honored to be serving as this year's Chair of Programs Committee for GAHE. Today we do have a packed agenda, so we'll take just a few minutes for some important chapter announcements and then move on to our program, Disruption, Innovation in Healthcare Delivery. I'd like to start our meeting by recognizing our sponsors and expressing our gratitude to these corporate partners. We truly would not be able to put on these events without all of you. Our platinum sponsors are Wellstar Health System and Sejenga and Partners. Our gold sponsors are Cancer Treatment Centers of America, Protivity, Metro Atlanta Ambulance, and Philips Healthcare, as well as HCA TriStar Division, Beck Group, and Sound Physicians. Our silver sponsors are DT Spade, KCA Firm, SSR, and Nagel and Associates. Thank you again to all of our sponsors. Our upcoming virtual events, and mark your calendars. We've got February 18th, our monthly virtual Lunch and Learn, Equity of Care. That will be from noon to 1:30. And it is for 1.5 hours of ACHE face-to-face credit. That registration is limited to 65. And we will actually be focusing next month on that February 18th date in compliance with the vaccinations. More details will be available on our website and registration will be announced soon. February 24th webinar, Documentation and Communication Best Practices. That will be from noon to 1 for 1 hour of ACHE qualified credit. March 3rd webinar, Evolving Technologies Impact to Programming from noon to 1, also for 1 hour of ACHE qualified credit. Both of those events will also have more details and registration will be announced soon. March 22nd through 25th is our annual ACHE Congress on Healthcare Leadership. That will be virtual this year. You can earn up to 12 hours of ACHE face-to-face credit and learn more and register at www.ache.org. You can also visit our events page at www.gahe.org for details and registration for all the events above. GAHE also offers several ways to stay connected through social media using Facebook, LinkedIn, and Twitter. We ask that you connect with us and follow to stay updated with all of our events and announcements. We'd also like to invite you to get more involved by serving on one of GAHE's committees. You can contact GAHE for more information or check out our website. Today's program, as mentioned, offers 1.5 hours of ACHE face-to-face credit. Our topic today is Disruptive Innovation in Healthcare Delivery. As you can see, we have an outstanding panel, and it is my pleasure to introduce our moderator, Trent Lind, FACHE, CEO of Eastside Medical Center and our president here at Georgia Association of Healthcare Executives. Trent Lind has over 20 years of extensive healthcare experience serving in a variety of healthcare leadership roles within a number of markets throughout the United States. Trent has served in executive leadership roles within Hospital Corporation of America for over 18 years. Trent came to Eastside Medical Center by way of Texas Orthopedic Hospital in Houston, Texas, where he served as CEO for 4 years. Trent began his role at Eastside Medical Center in January 2016. Trent has spearheaded many growth initiatives within the Eastside network to expand healthcare access points throughout Gwinnett County. Trent has led the development and implementation of the Eastside Urgent Care Network, which is now the largest urgent care network in Gwinnett County, consisting of 5 urgent care centers. Under Trent's leadership, Eastside Medical Center was awarded the 2017 and 2018 Healthgrades Patient Safety Excellence Award, a distinction that places Eastside Medical Center among the top 5% of all short-term acute care hospitals, reporting patient safety data for its excellent performance. Trent earned a Bachelor's of Arts in Political Science from Wake Forest University and a Master of Healthcare Administration and Master of Business Administration from the University of Alabama at Birmingham. With that, I'll hand it over to Trent.
Thank you very much, Angela, for that nice introduction. Way too much included there, but appreciate the time you took. I have the honor and privilege of introducing our guest panelists today. I'm going to start with Brent Asplund. Dr. Asplund is the president of Village Medical, and I think a lot of us have heard of Village Medical and the work that's happening there, and excited to introduce Dr. Asplund as we'll hear from him today. Again, Dr. Asplund, president of Village Medical, the employee primary care group within Village MD. Prior to this role, Brent was Village MD's chief operating officer, which he had accountability for execution across all of Village's markets. An emergency physician, Brent previously served as chief clinical officer for the Fairview Health Services in Minneapolis and Mercy Health in Ohio and Kentucky. Dr. Asplund has led system-wide transformations that drove success in value-based care in multiple settings. He also served a range of emergency medicine and other leadership roles with the Mayo Clinic and Health Partners in Minnesota. His counterpart today, and I think probably in life as it comes to Village MD, is Paul Martino. Paul's the co-founder and chief growth officer for Village MD. Paul Martino is the co-founder and chief growth officer of a leading provider of healthcare for organizations moving toward a primary care-led, high-value clinical model. His responsibilities include identifying and addressing market needs, growing the base of affiliated primary care physicians, developing strategic partnerships, and expanding the reach of the Village MD brand. A 30-year veteran of the healthcare industry, Paul has driven growth and fostered innovation as an executive for health plans and constituencies. Prior to Village MD, he was Senior Vice President of Clinical Strategy and Innovation at Anthem WellPoint, the second largest health plan in the US. He was instrumental in architecting Anthem's payment innovation strategy, developing its patient-centered primary care model, and establishing value-based contracts with Anthem's primary care physician network. Paul holds a BA in philosophy from the University of Connecticut. So really excited to introduce both of these individuals. We've had a chance to connect over the past week and get to know each other a little bit. When I think about, and as we sent out in our prep for this meeting, we think about what disruptive innovation is. And we sent out a definition as kind of the teaser for this. Disruptive innovation, a term coined by Harvard professor Clayton M. Christensen, is a transformative business model that leverages technology to help focus on making products and services more accessible and affordable. And so we're excited to hear about Village MD's model. Obviously, Village MD is not only moving across the country in a big way, but they're moving into Georgia in a big way. And I'm actually having some personal experience with them as we evaluate options within my organization. But really, you think about the term disruptor, and it's kind of ironic because the discussions that we're having are all about alignment. And so we're really excited to have this opportunity today to hear firsthand from our founders of this organization and our leaders of this organization, and how this may affect healthcare nationally, but certainly in the state of Georgia. So at this time, I'm going to turn over to Dr. Asplund. Brent, if you could walk us through your overview slides, and then we'll get into questions from there.
Good afternoon, everybody. It's a pleasure to be here. And we really look forward to today's conversation. And you kind of walked through the introductions. I don't think we need to spend any more time on introductions, but we're going to save a lot of time for a dialogue, a conversation back and forth with your questions and our perspective, both on at-risk primary care in general across the country, as well as how we think about the Georgia market. And we want to start by giving you an overview of the model. And it's great to have Paul, one of our 3 co-founders, here on the call. So Paul, why don't you take it away?
Thanks, Brent. I appreciate that. And Trent, I don't know if you're for hire for introductions. I've never actually read through my bio before. It sounds like I've actually accomplished a lot, and and I can't say that it's been easy. Certainly here at Village, as one of the founders of the company, we had this idea back in 2013 that there was a better way to approach the healthcare, the healthcare, I'll call it marketplace. I don't always like to call it marketplace, but the healthcare marketplace. And from our perspective, and my experience was shaped by 32 years of working for health plans, and mostly, frankly, getting it wrong. I always thought that we were an organization as a plan that did certain things well and we did other things less well. And I think the things that we did less well were really understanding the dynamic of the physician-patient relationship. We had all kinds of programs, disease management type programs, and utilization management, all these things that are kind of core competencies of a health plan. But I always often wondered, do people really value them and do they appreciate them? And as I stepped out of my role at Anthem back in 2013, I got together with Dr. Clive Fields and Tim Berry to start Village MD. We thought about leading with primary care, which at the time seemed like a great idea. It seems to be all the rage right now. People call it the white hot space, being at-risk primary care models. For us, it's a team-based approach. It's a clinical model. If you take nothing away from this conversation, we started with a clinical model. There's lots of other models out there. There's subsets of populations that focus on only things like Medicare Advantage populations or dual eligible populations. Ours is a clinical model that's intended to work and support a physician who's working in a community today supporting a panel of patients. That's our model. So we want to take what's already going on in, let's say, the Georgia market, more specifically the Atlanta market, and we want to try to help those providers that have been slugging it out for a long time, trying to help their patients. And as the market is moving to value-based care, as we call it, risk-based care, as we call it, whether it's government programs or commercial programs, we believe they need help. And I also think that the help that they need has been accelerated by things like the COVID pandemic. The COVID pandemic had a big impact on a lot of independent practicing physicians. I think it made it harder for them to remain in independent practice. I think a number of them were caught flat-footed without the competencies of things like telehealth, and it hurt. And so I think a lot of those physicians are now looking at the market saying, am I going to keep slugging this out on my own, or is there a better way to do it? So for us, we want to support what's happening today in the market. We want to support those physicians that believe there's a different and better way to care for patients. And we want to be there shoulder to shoulder, helping them accomplish that. So that's kind of what we're doing. Brent, if you would advance the slide. So what do we look like today? We look like a company that's now almost coming up on 8 years. In April of this year, we'll be 8 years old. We work with about 2,800 physicians, really primary care providers. We're doing it today in actually 11 markets, soon to be 13 markets. Our stated objective as a business is to add 2 to 3 new markets per year. And then what we'd like to do is grow to 20% or so of the available adult primary care physicians in a market. We serve 3 million patients today, and the company has grown fairly quickly. As you look at the light blue states on the map, we've systematically entered various states. And then what we try to do is, as I said, grow a presence in that state. So I look at Texas, we entered Houston in 2013, but then later we added, more recently, we added both Austin and El Paso. We announced those earlier, well, I guess it was now last year. One more, if you would, Brent. You'll hear a lot of noise about us in things like our partnership with Walgreens. That seems to be getting a lot of people's attention these days. For us, we think the pendulum is swinging from what I would call from historically more institutionally based care to now more ambulatory based care. For us, we think that care gets delivered in multiple settings. So in clinic, which is customary, that's what's been going on for quite some time. Virtual visits, I made reference to the pandemic earlier and some clinicians being caught a little bit flat-footed and not really ready to jump into virtual visits. Interestingly, over the last 9, 10, 11, 12 months, I think people often ask me the question, were you doing virtual visits before COVID? And my answer is we had the ability to do them, but because physicians weren't compensated in what I would call a fair and equitable way, there was no benefit for them to do them as long as patients were willing to come into the clinic. And we now all know that's changed. The last point I'm going to make is around home-based care. We mentioned team-based care on the first slide, home-based care. We think tethering patients to and clinicians to home, community, clinic settings and virtual, we think this is sort of the model and the wave of the future. And so this is sort of the way we do it. We do televisits in a big way, kind of ebbs and flows based on what's happening, right? As the COVID pandemic has it cooled off for a while and it spiked up again, we saw an uptick in virtual visits. So a model that we're here to support and to support with across all of our providers, across all of our markets. One more, Brent, if you would. This is the care delivery model, and it looks like a really busy slide. I don't know if there are any clinicians in the audience, but because I've said it now multiple times that it's a clinical model, what I'd like to do is turn it over to you, Brent, as a clinician, a physician, to actually talk a little bit about our clinical model.
Absolutely. Thank you, Paul. Appreciate that. We really do believe that to manage populations to both better clinical outcomes and lower total cost of care, you have to be present in a traditional office setting. You have to be present in the neighborhood, which is core and fundamental to our partnership with Walgreens. And you have to get into the home. And you have to be able to do all that both in person and virtually. And so that's what this clinical model intends to do and is delivering in our markets today. We really are an embedded model. We look to establish a long-term partnership with a physician and her panel of patients. We have both an affiliate model and Village Medical, which is our employed medical group. We'll get into that here a little bit later on. But suffice to say, we started as an affiliate only model back in 2013. And for a few reasons, we felt that having an employed medical group option was a strong opportunity for us to grow. And so we began Village Medical with Dr. Clive Field's practice in Houston and another successful at-risk primary care group in the Houston market in mid-2019. We added another affiliate in our Kentucky market at the beginning of 2020, and then launched a year ago now in the Arizona market with Village Medical. Arizona was the first market that we entered with our employed group, Village Medical, as the first presence in the market. In the Georgia market, we began with an affiliate model 3 years ago and have now announced the introduction of Village Medical. We want physicians and their care teams to come into the clinical model on the path that they choose. We don't believe we have to employ everybody to be successful in this model. We've driven really good results working with affiliates. The clinical model is the same, whether you're an affiliate or in Village Medical, the group. From a payer, we use a mechanism that the way affiliates access our contracts is through the same entity. And so we look to a payer like a large group, whether the participating physicians are affiliates or are part of Village Medical. The other drive for the Village Medical employed group was our partnership with Walgreens, which we'll spend some more time talking about. I'm not going to get into the details in chapter and verse on the clinical model. Happy to answer any questions, but I want to talk about the core principles of it, which is this is a partnership, whether you're an affiliate or part of Village Medical. It's a long-term partnership. We're going to make investments in your practice as a primary care physician. We're going to bring not only the value-based contracts where you can be rewarded for better quality and lower cost, we're going to invest in your practice with both clinical professionals and a team we call population health operators to bring you actionable information about the panel that is at risk, to partner side by side at the elbow with you and your care team to redesign workflows so that you can succeed and we can succeed together. And we'll make these investments understanding that depending on where the practice is when they come into the model, it could be 2 or 3 years before we're seeing really strong results on the value-based side. And we meet practices across the spectrum, really from pure fee-for-service to groups like the one I mentioned in Houston that have had a long track record of being very successful in at-risk arrangements. And as long as the physicians are committed to going on the journey with us and bringing the elements of this clinical model to life, we're happy to make the investments and work with them over time, even if they've never been in a value-based arrangement. Our model is about getting visibility to the population at risk, understanding who's sick and who isn't, where they're going, and then driving a predictable, proactive, high-touch, continuous clinical model where depending on the risk severity of the patient, we could be implementing as many as 20 to 25 touches with the patient during a year across a broad spectrum of professionals, the PCP, often an APP that is in a team model with the physician, our care management staff, and our home-based primary care professionals. So all of those are going to come to bear in the clinical model. It really stands on a technology platform, which we call DocOS, which we began looking at the data. And the core, one of the core reasons why at-risk primary care is different right now is the system is wired. And so we can bring in fully unredacted claims data from all payers. We bring in clinical data from over 55 different EMR instances. We bring in payer reports, health information exchange. We'll take ADT feeds from facilities and of course pharmacy, lab, and other data, and put it into a common data model in DocOS. And that operating system drives every element of our clinical model forward. And so this team-based at-risk primary care model really stands on what we call the quad, the 4 areas that if you can execute in each of these 4 areas, you're going to drive better clinical results and lower cost of care. I often say we could put this slide on the front page of the New York Times. It's not a trade secret. It's about execution and building trust with primary care physicians and their care teams and their patients, and really helping enable better outcomes through execution and taking action in real time on data that come out of DocOS. So we think about success in the clinical model through panel management, which is just driving visibility to the population at risk, driving visit frequency based on our internal proprietary risk stratification algorithms, driving an annual care program, and setting up specific opportunities for those who can benefit from home-based care. Clinical documentation and quality, we're unlike some models and other organizations that really almost exclusively focus on risk score and clinical documentation. We certainly invest in that and want to accurately describe the severity of the population. However, we're not looking to have the highest risk score. We've driven MLRs in the low to mid 60s and sometimes upper 50s with risk scores in the 1.2 to 1.4 range. And so that just emphasizes, I think, why this is such a clinical model and where our focus is. On the quality side, we're grabbing the information in real time and looking to close gaps and make sure that we're driving things like medication adherence. And we really believe in the power of integrated pharmacy with at-risk primary care. And then we have 3 utilization programs, from our proactive care management to a post-acute and reactive care management capability that includes contracting and forming preferred post-acute networks for skilled nursing, and other services in the post-acute setting. And then our home-based model is physician-led, mostly nurse practitioner delivered, but we've seen reductions in hospitalization rates of 40% for those patients who are truly at the frail end of the risk spectrum and just aren't able to engage with the ambulatory system very effectively. Getting into the home and delivering really a full spectrum of primary care is critical. I mentioned DocOS, and this is another description of it. Like I said, we started with the data, and then those workflows against those 4 areas of panel management, clinical documentation, quality, and utilization are what really make the model scalable, and why, in our view, we're seeing results in multiple lines of business across multiple geographies. So that's commercial, Medicare fee-for-service, Medicare Advantage, Medicaid dual eligible, and it's because of the scalability. You know, I often say to docs, it really doesn't do you much good to find out that Mrs. Jones was admitted 6 times for heart failure in 2019 on January 21st, 2021. But often that's about the time you find out if you're just waiting for the final reconciled payer reports to come out. It does you a lot of good to know that Mrs. Jones was in the emergency department last night, and if you could get her into the clinic today, it could make the difference between her bouncing back and getting admitted. And these are some of our results that we've been privileged to see in terms of patient experience, our utilization rates, clinical quality, and total cost of care, which we're proud of. But it's really, like I said, about building trust with physicians, APPs, care teams, and patients, and using the data that are in our DocOS ecosystem to roll our sleeves up and go to work every day, wake up every morning looking to drive better clinical outcomes. We wanted to do just a couple of minutes on the Walgreens partnership. Paul was instrumental in the origins of this partnership, and we're excited about it. So I'm going to hand it back to Paul, and then we'll get to your questions.
Thanks, Brent. So this is a little bit of the press that we've been getting around this partnership with Walgreens. For this section of the discussion, if you take nothing away from it, the historic model of the co-located clinics for Walgreens, and Brent, you're free to move that slide if you'd like. They're true full functioning primary care clinics. So this is a picture of one. I'm going to guess this might be the Inwood location, Brent, in Houston is my guess. And so it's a picture of the external and the waiting room of the clinic. These are, when I say full functioning primary care clinics, these are a good sized clinic. They're 3,300 square feet in the small format, 9,000 square feet in the large format. Exam rooms, 9. Telehealth is available, co-located behavioral health, and a lab with flat panel imaging. So it's intended to provide a broad range of primary care services, similar to what you would get if you walked into just a regular clinic. Interestingly, the original idea, when a dear friend of mine, a health plan guy for years that I've known, was the chief strategy officer for Walgreens back 2017. And when he told me he was planning to leave the company to retire, I said, you know, I'd love to meet the team that runs the clinics. And the reason for that was in Houston, they had not picked a health system partner. They were Walgreens was actually operating the clinics themselves. So we had a chance to get up close and personal to those clinics and really see if they kind of met what we thought was the right need. And the answer was not really. And so we pursued a different path, and for us, that path was to build these primary care clinics. Somebody actually one time said, when we showed this picture, did you actually build onto Walgreens? And the answer was no. We actually were able to work with Walgreens in a collaborative way where they actually cleared out 3,300 square feet of the existing store footprint. So what you're looking at in the top picture, the left-hand side where it says Village Medical, used to be part of the Walgreens. It extended down, and we essentially stripped it out, repositioned the face, the facade of it, this, new signage that's got a separate entrance. That's a door in the about mid picture. And so there's an entrance from the external. So the clinicians, when they go to work every day, feel like they're walking into an office, medical office. if you were inside the Walgreens, there's an entrance from the Walgreens into the clinic waiting room. So that's the bottom picture. And we don't have a picture of it here, but the back of the clinic has an exit that's a keypadded door. And so the idea here is the patient can actually leave the clinic. They walk down the OTC aisle up to the pharmacy. We prioritize prescriptions so they get sort of preferred status, so minimize the wait time. And the benefit of the co-location, as Brent mentioned, is that Walgreens committed to having a clinical pharmacist available to us on a sort of on-demand basis. So the clinical pharmacist can actually enter the clinic through a keypadded back door. And so we can do things like med reconciliation, med consult, medication therapy management. We can do that before the patient ever leaves the clinic. Little factoid for you. The no-fill rate for retail pharmacies is about 25%. And as Dr. Fields and Dr. Asplin would say, if I've written a prescription for a patient, it's likely because they need it, and it's shameful that 25% of the time it's never filled. So we have the ability to actually drive down no-fill rates to mid-high single digits. We also have the ability to drive improved compliance, and I'm going to invite Brent to talk about that. But we thought this was a really good idea. And so the good news here now, almost 4 years later, is so did Walgreens. After we spent the first year coming to know each other a little bit and talking about what a model could look like and arm wrestling, they said, let's do this. They said, you pick a market, we'll pick a market. We picked Houston because it was our first market, and they picked Phoenix. And Brent mentioned earlier that we've opened de novo clinics in Phoenix. We acquired a clinic in Phoenix, and we have now multiple Walgreens co-located clinics open. So it's been an interesting journey. And earlier this year, about a week or two ago, Walgreens accelerated their investment in our company, and we committed to building no less than 600 to 700 of these clinics over the next 4 or 5 years. So Brent, I would ask you, is there anything you want to add especially around the clinical model? You've spent a lot of time working on it.
Absolutely. I mean, I think this fills in that piece, the neighborhood piece of the puzzle, where we think we need to be from a footprint standpoint to successfully manage populations. But pharmacy integration, we operate and own our own pharmacies and have had higher than 5-star med adherence by using integrated pharmacists as part of the clinical model. We're doing collaborative practice agreements with Walgreens. And so we really based the clinical model on our own success with our own pharmacies in Houston. And we're replicating that now at scale with Walgreens. So in the collaborative practice agreement, we don't have to have a lot of unnecessary calls back and forth, which take up care team time and pharmacist time around things like bridge refills and therapeutic substitution and prior authorization. So those types of things will be taken care of through this, which can help set up probably the most important clinical element, which is adherence. So we have a med synchronization program where we anchor all med refills and do 90-day refills. And then we're also leveraging the pharmacists for consults. So we can do health outcomes pharmacists, consults for high-risk patients, for immediate post-acute care transitions and med reconciliation. And there's really a tremendous value. And I think clinical pharmacists are likely the most underutilized clinical professional to drive differentiated outcomes for populations. And so that's what we're doing with this model. We'll also have the opportunity to deliver telehealth as a provider on Walgreens Find Care, which is actually the most frequently visited medical related app out there. They have millions of visits per month on that app. And we also will be doing telepharmacy with them. So it's an exciting partnership, and we look forward to answering questions you have about it. We just opened our 10th co-located clinic Tuesday of this week. So we have 2 in Phoenix and 8 in Houston now. So with that, we're going to transition to your questions, and back to you, Trent, and happy to have the dialogue.
Fantastic. Thank you, Dr. Asplin. Thank you, Paul. Appreciate the intro. That was really enlightening and really helps to set the stage. So As the moderator today, I have the ability to kind of navigate us in the direction we want to go. And what's really exciting for this session, and we've heard your feedback from our membership. We've heard you all ask for a more interactive session. And the great thing is both Brent and Paul, as we started this dialogue, said they wanted this session to be very interactive as well. So what we've done, we've switched back. We've got our screen up so we can see everyone that's out there. If you're eating lunch, you can keep yourself off the video. We understand. But we really want to open this up. I'm going to start with a few questions. I've already seen in the chat box that many of you are adding questions to the dialogue. So what we'll do is we'll pause kind of throughout and have Bruce present some of these questions as well. And then when we get to the later portion of the discussion here in the next 30 minutes, we'll actually open it up for live questions that may be out there as well. So a couple different ways and formats of ways that we can get questions out there, but really want to make this an interactive conversation. And that was really what Paul and Brent wanted for this. But let me kick off and maybe whet the appetite here for us. We talk about this at-risk model, and we talk about what this looks like from a success standpoint. We heard a little bit of that in your intro, but when I look back, we've been down this path before, and whether in the 90s or before, where this has been really a fad, and the at-risk primary care model has kind of gone full circle a few times. And I think we're interested in knowing, one, what are the success factors? And again, I think we heard a bit of that, but I'd like to hear that again. What are the success factors? And then two, as part of that, why is it different now? Why would this, is this going to be another fad, or is this really the future of where we see primary care going? So with that, let me maybe start with Paul and then shift over to Brent and get your thoughts.
Yeah, I'm gonna address the part about, is this just the latest coming and going fad, and then I have my ideas about what success looks like, but I want to hear from the doctor what success looks like, because in the end we're working with doctors. So I don't think it's a fad this time, Trent, to be fair, and I again, my experiences were shaped by working on the health plan side. So I spent 32 years inside of the health plans, which have historically been the quote unquote risk-bearing entities. But in the end, really the employers are risk-bearing entities because they're mostly self-funded in the commercial world. And then the government is on the Medicare and Medicaid side. We actually have lobbyists in DC, which is not necessarily common for a company of our size. And I mention that because I think part of what we're trying to accomplish is to keep an ear to the ground on how CMS is thinking about it. For those of you that have been tracking CMS over the last several years, we started out with pioneer ACOs, and they've kind of gone by the wayside and a little bit bust maybe. That was replaced with Medicare Advantage, MSSP type programs, Medicare fee for service, MSSP. And the government, in my view, is pushing everyone to risk. They're doing it through Medicare Advantage, so think payer. Medicare Advantage payers are pushing providers to risk, guys like us. We like actually globally capitated contracts. And Medicare fee for service most recently, so 2020, announced two things. One is the geographic option, and two is the direct contracting entity. So the direct contracting model, we applied for 7 of those entities, DCE as we call it, and we were approved for all 7. They're either partial risk or full risk, and we were approved for both. Later in the year, so fairly recently, maybe November, December, they announced the geographic option where you as a provider would have the opportunity to take a cost responsibility for an entire geography. So think of it as a micro MSA or a full MSA. So I don't think the government's backing off. My experience walking around health plans, certainly on the government side, they're not backing off. And I think everybody would like to see it be successful in the commercial world, which is why we remain in the commercial world today. So I don't think it's going away. Brent, how would you answer the question around success?
Agree with everything you said. Let's start with the clinical model. I think the reason it didn't work in the 1990s is that it was a gatekeeping model, and the public didn't trust it and doctors didn't trust it. Our clinical model is not a gatekeeping model. We do not want to stand between the patient and the care she needs or he needs. in order to get a better clinical outcome. And so we're looking to accelerate and move upstream and manage chronic conditions more effectively, leverage pharmacy integration, leverage the types of elements of the clinical model that I just spent a few minutes talking about. And so the public lost trust because of the gatekeeping orientation of the HMO movement in the 90s, and that's just not how we're approaching at-risk care from a primary care clinical model at this point. The second is really that in the 90s, the system really wasn't wired anywhere close to where it is now. And so getting real-time actionable information was just much more difficult. And it's not easy today, but it's possible. And that really wasn't the case back then. And then the third, all the stories, again, this is all part of the trust element as well. There was a reason that enrollment centers for Medicare plus choice back then were, and some commercial HMOs were on the second floor of buildings that didn't have an elevator, because plans and others were rewarded by staying away from risk. And I think the risk adjustment models have matured a lot, and we want risk. We want to take care of the most frail, those who have the most chronic conditions, because our model really succeeds in that setting. And so if you have a structure where the public doesn't trust it and the health system is looking to avoid taking care of sick people, it's not likely to be successful. And neither of those are the case. And so I think that it's really different this time around. And then just simply the capital inflow. There's a lot of barriers that could stand between us and being successful. There are other players in this space, but there's a few things that I find really gratifying about the position we're in. Our success does not depend on anybody else's failure. Our biggest competitor is the status quo, not other at-risk primary care organizations. And while there may be barriers between us and the success of the vision we just outlined for you, capital will not be one of them. And so the more successful all the players are in the at-risk primary care space, from my point of view, the better it is for patients, the better it is for primary care, and the better it is for the affordability of our healthcare system. And so those are some of the reasons why I think it is really different this time around. And this pandemic has accelerated this, completely accelerated it, and kind of laid bare some of the inherent weaknesses of a fee-for-service dominated reimbursement system. And I know you all live that every day.
Well, thanks for that response. It does lead me into one more question that I want to pause and ask Bruce for questions out there in the audience. But so from the hospital side of the equation, there's obviously fear and change. I think that's just innate human nature. But certainly some of the more traditional models that we've seen where primary cares are either employed by the hospital, the acute care side, or where there's a strong affiliation with these independent private practices. Tell us a little bit about the alignment opportunities, because again, we talked about you guys getting coined as disruptors, but really at the end of the day, in our discussions, it's really been more about how do you align or maybe realign current relationships to still foster a partnership on the acute care side that benefits all parties, and especially at the end of the day, even with the more important focus, which is patient outcomes. So maybe talk a little bit about that and what hospitals should see in this model that may actually make an attractive change.
So maybe I'll start, and then Brent, again, I want to hear your point of view. And what I love about Brent's background is he spent a good amount of time working at really large health systems, excuse me, like Mercy / Bon Secours and Fairview. So he's got lots of relevant experience. And in fact, when Brent worked for Fairview, it was in a model not dissimilar to the one that we're describing. So first, for me, good hospital care, good institutional care, good required interventions, surgical interventions, whatever they may be, is an important part of our model. We need good hospital partners. So I hope people hear that. We also believe that we need good ambulatory support and specialty services, whether that's imaging, infusion, proceduralists, procedures, whatever it might be. We need good care. I don't know if we need as much as happens today, but we need good care for our model to be successful. And so we like hospital partnerships. We explore them. The call Brent and I were on just before joining you all this morning, Trent, was with a health system in one of the states that we're in, exploring deeply. We're way past the let's get to know each other, and we're into the weeds on what the operating model and the governance model would look like. We have a health system partnership in one of our states today, in Indiana, and I would say that we have a great relationship with your organization, Trent, HCA. So we're looking for them and we need them. Brent, how would you answer that question?
Yeah, I echo your comments. Look, I started my career as a paramedic. I'm an emergency physician. I love hospitals, right? So my whole clinical background was hospital-based care and pre-hospital care. And we're certainly, we're by no means anti-hospital, because we're never going to build a hospital. And we need good partnerships. And for the most part, we are not employing specialists either. We will bring a specialist into Village Medical if they're part of a group that we are acquiring, but in general, we're not looking to employ specialists, with the exception of some cognitive specialists. So I think it starts with we're building to succeed as an at-risk primary care organization that includes both affiliates and employed primary care providers. By definition, you have to be a high-performing primary care group. So my first question I would pose is, why wouldn't you want to be closely affiliated with a high-performing primary care network that not only succeeds in delivering traditional primary care services, but knows where patients are going and is actually actively managing where patients are going? In our experience, my own experience, I'll speak from that chair. The fact of the matter is, the health systems I worked in, until we got really deep into value-based arrangements, just assumed and really didn't know exactly where people were going even from their own employed primary care group. And so I'll say the numbers so that nobody gets put on the spot here, but we thought we were doing really well if we were losing $130,000 a year for a primary care physician, and it was north of 200 for some, and for specialists it was an even larger number. And now, yes, some of that is accounting, right? But it's not all accounting. So there's a huge investment to employ primary care, and with that investment, often, in my experience, comes an assumption that you're getting the downstream referrals. But if you look closely in an unmanaged employed primary care group, as much as 50% of care can be going outside of the system, depending on the market. And in a highly managed, unless it's a narrow network product, you're still likely losing 30% to 40%. And so with a high performing primary care organization, we're going to be able to control where people are going more effectively than in an unmanaged fee-for-service primary care group, number one. I would shift also to Medicare admissions. I mean, most the early wins in these at-risk arrangements are with globally capitated Medicare. Most health systems do not make money on Medicare admissions. There's some DRGs where you do. And I know there are some exceptions where there's good profitability on the Medicare side. But if the demand destruction is at a place where you don't have contribution margin today, just you think about that actually there's an opportunity cost of an unprofitable Medicare admission and major capital investment to build out more capacity. So if you can rationalize your capacity and move some of your mix from an unprofitable line of business to profitable, while perhaps even participating in some of the partnerships through the value-based arrangements. That's not a bad trade-off in my view. And so I was always a strong advocate when I was on the health system side to say, look, it's not going to hurt us to be working with a really high-performing at-risk primary care organization. And you don't have to worry about Village MD going out and building a hospital. It's never going to happen. We might do hospital at home, but we're not going to build a bricks and mortar hospital. So that's how we're looking at it, but happy to hear other perspectives on it.
Yeah, very, very helpful. Appreciate those insights. Let's take a moment. Let's shift. I know, Bruce, if you're able to begin to read, I know we had several questions that are coming through and certainly pertaining to this particular topic around the acute care impact, but also around specifics, also around the impacts here in Georgia and what the vision there is. So, Bruce, why don't you take it away with some of those questions, please?
Sure, Trent. We have several questions in the in chat, so I'm just going to take it from the first questions and work our way down. What's the role, if any, for a freestanding, clinically integrated, multi-specialty IPA consisting of 500 plus independent providers in an organization like Village MD?
Well, the easy answer might be call me up. But in fairness, we work with multiple IPAs. We have worked with them. We have an active IPA in Georgia, in the greater Atlanta area that we work with. In more than one instance, we have actually acquired the IPA. And part of our model, and we didn't say this in the description that we gave as kind of the opening, we're in it for the long haul. And we have to ask our clinicians and our clinics to be in it for the long haul. And one of the disadvantages, in my view, of an IPA is that the affiliations are generally kind of loose. Most IPAs that we've experienced and worked with, a provider group could actually leave the IPA with a relatively short notice period, usually something like 60, 90, 120 days. When Brent described our model, the clinical model is what I'm talking about. It is a capital and people intensive business. And we make the investment. We're not asking a physician group or a physician individually to make an investment. We're not asking them to take on risk. We're doing the investing. And the only way for us to get a return on that investment is to have a long-term relationship. And so we do that through a professional services agreement in the affiliate model. And the duration of those agreements are usually 5 years. And and then, of course, there's the employed model, in which case the provider actually becomes, the provider or group could become and do become employed by us. So we like IPAs. They've already done the work of figuring out which doctors are interested in being what I'll call organized. We just need a little bit of a different layer of commitment around it. Brent, would you answer it differently?
No, I think you covered it very well. And I just emphasize again, to really get to the type of contracts that we can really be successful with in the clinical model, we need to look like a large group. And we do that through this funds flow opportunity. And so the independents in the IPA will access the value-based agreements through the PC that we establish in the market. So that's another layer that's a little different. And we have a technology solution that does that. And we've been very successful with it, but that's just another layer of the commitment that's required. And so that's another element of a partnership, but I would end with the same way Paul started, which is give us a call.
One last thought, Trent, before we go to, or Bruce, before we go to the next question. As a former payer guy, one of the things that frustrated me was when if we offered a better financial arrangement to one IPA or another IPA, what we often saw was that providers would move if they thought they were going to get better reimbursement from an IPA. So there was this, I'll call it fee schedule shopping that was going on. And as a payer guy, I hated it because it felt to me like all I was doing was competing against myself to push up cost. So one of the things that we are very protective about our model is we don't want to be viewed as somebody that goes and tries to negotiate more aggressive value-based contracts with plans and then turns around and shops them to try to get participation. Again, that's why we're in it for the long haul. If you're on the plan side, you know that these, especially in the commercial market, these arrangements take a long time to even determine if you've produced any value, any shared savings, as we might call it. And so we have to keep a panel fairly stable in order to make sure that we're measuring what we started with and what's being included in the performance period. So we also are trying to be a good partner to the plans.
Okay. The next question has two parts. Are you using predictive analytic algorithms to help proactively manage your patient population? And if yes, can you share 1 to 2 examples of this, the action your team takes with the information and the results you've realized?
Yeah, I'll take the lead on that one. Absolutely. We have 3 different proprietary risk stratification algorithms. 2 of them are based primarily in Medicare and 1 in commercial. So the first 2 utilize and leverage the data from DocOS to predict the top 10% of spend in the population for the next 12 months. So if you have 50,000 Medicare lives, who are the 5,000 that, or what actually of the total 50,000 member spend, and where is the top 10% of that spend going to come from? So probably around $550 million of spend. So which beneficiaries are going to account for the top 10% of the spending and be the most costly members? The second algorithm does the same thing for commercial. And then the third one is really a frailty index that drives the use of our home-based primary care model. And so an example there, we can do 3 types of care in the home in general categories. One is if for whatever reason an individual hasn't been to the office for an annual wellness visit, we can go out to the home and do that. But the more interesting examples that would come from the predictive algorithm, especially the third, the second is supporting patients in the immediate post-acute period who are at the highest risk of readmission, and our algorithm helps identify who is most likely to be readmitted. And then finally, there's a subset that stratify as likely to benefit from ongoing longitudinal primary care in the home. So that algorithm helps us select who those individuals would be. Of course, we'll also take referrals from providers. And then in the general population, we're going to use our high-risk stratified algorithm to determine who is engaged by our multidisciplinary care management group, which includes nurses, but also licensed clinical social workers and resource coordinators that are aware of what resources are available in the community and are frankly addressing social determinants of health needs in the population. And so we use the algorithm, and it runs every month, and we'll engage with our high-risk population to determine what their needs are. Our preference is to engage them live in the clinic, and so that team is embedded, but we also have telephonic outreach. So I'll stop there.
All right, next question. Does Village Medical multidisciplinary team incorporate behavioral/mental health services, or will you, if you know already?
Yeah, I'll start. And Paul, if you have any other comments, please chime in. There's no question that having a behavioral health comorbidity is really a multiplier in terms of making it more difficult to achieve optimal clinical outcomes and adding expense. And so, as I mentioned, we incorporate behavioral health into our multidisciplinary care management team. And most of our social workers are licensed clinical social workers, so can do some elements of counseling. We do have some co-located behaviorists, and we also engage with community-based behavioral health specialists. I think one of the advantages here is that we're able to leverage telehealth for a nice portion of this care. And that said, this is an area where we are continuing to invest, and we'll be building out additional elements because for all the success we've had, there's still a need to do more. Paul, would you add anything to that?
No, I think you covered it. I would just maybe take it one step further and say, and in our multidisciplinary model, not just behavioral, but we look at all specialists, right, Brent? We in markets that are mature markets for us, like Houston, we employ endocrinology, we employ physical therapy. So it's truly an integrated model.
Okay, another question. What are your thoughts or plans, if any, to vertically expand your scope of services to compete effectively with those available at Walmart's numerous health centers propagating in Georgia?
So maybe I'll start and then see what Brent has to say. What I don't want to do is compete with Walmart. Like it's not in our DNA. We've got a specific strategy. We've got a specific business approach. We've got a specific economic and business model. And so for us, I'm going to again point this one to Brent. We've been to the Walmart clinic. We know what Walmart's trying to accomplish, and it's different than what we're trying to accomplish. I would say the same thing about Aetna CVS with their health hubs and their minute clinics, and I would say the same thing about other what I'll call at-risk care providers. Some that are in the Atlanta market, some that are coming to the Atlanta market, whether they be ChenMed and Iora and Privia and Aledade and Agilon. We know who they all are. And they all do great work. And frankly, what Brent said earlier, I echo. We want them all to be successful. Inertia is our biggest, is the biggest weight of value-based care having screaming success. And we want every one of those organizations to be successful. That said, when you looked at the picture of the clinic at Walgreens, the one that we showed earlier, with the separate entrance, and I would call it an elegant waiting room, we're trying to create a specific image. We're trying to create a specific model. We're trying to create a specific place of employment in that example. I don't know if any of you have been to the Walmart clinic, but it's in the center of the store. So if you're a clinician that's going to work there, you're going to walk through the center of the store. And what we heard from our doctors, the ones that we work with, is that they wanted to be treated to the degree of professionalism that they've earned through the licensing of being a doctor. And so we're going to stay true to that. Brent, you tell me, you're a doctor. What do you think about it?
I think it is different. I would echo your comment that we certainly look for these other organizations to succeed. There's some similarities that will certainly come into play. So, I mean, I think in terms of convenience and access and neighborhood locations, there's similarities there. But as Paul mentioned, we're building a medical group. And we talked quite a bit today about the clinical model. We haven't talked about the culture and the governance. And in our view, in order to be a successful medical group, you have to have local practicing physicians taking the lead, driving the clinical model forward, building the culture of the group. And so as I have conversations with physicians, a question that comes up sometimes if we're discussing having their practice work in one of these locations is, well, I don't know if I want to work for Walgreens. And it's a very simple answer. I don't want you to work for Walgreens either. I want you to be part of Village Medical, and we want together to build the most successful at-risk primary care group on the planet. And so that's what we're about. We can't phone it in from Chicago. It has to come to life locally in every market, and the physicians have to lead it. And so in the physical design of these spaces, that's the culture and the professional medical group feel that we're looking to build. That said, you're not going to see us going into dental care. You're not going to see us have an optometrist and selling eyeglasses and some of the other services that are there. We're really more focused on bringing panels into our clinical model and getting as quickly as possible to full risk arrangements.
Okay, this is the last question in chat at the moment. What happens in markets like Atlanta where Walgreens has retail clinic partnerships with health systems?
You want to tackle that one, Brett?
Yeah, sure. I think we've already identified dozens of markets that we're moving forward with. And in the vast majority of cases, we move forward with our model, and Walgreens may have an existing partnership in the market and they could coexist. The difference here is that those partnerships are driving the traditional retail clinic. And what we're doing is different in full service at-risk primary care, as we've articulated. And so it's really different clinical models, different businesses. I do think one of the things that we are spending a lot of our energy on is helping the public as we enter these markets with our co-located clinics and with other practices, help them understand that what we're doing is different. But for the most part, that is not going to be a barrier to us moving forward. There can be some unique exceptions, but we're going to move forward with this in dozens of markets around the country. Paul, would you add anything?
Yeah, I was hoping that you would say that, and then I wanted to chime in with this. We now have how many Village Medical clinics, Brent?
We have a total of 48 sites, and only 10 of them are co-located clinics. This is not going to be the only footprint we will have as Village Medical. We will have larger hub clinics. In fact, part of our partnership with Walgreens, there'll be times where we're not building a clinic at a Walgreens store. Rather, Walgreens is going to build a pharmacy in one of our larger Village Medical care delivery sites. So the partnership is structured along a number of different physical layouts.
So the takeaway for me, Trent and Bruce, is that we're going to continue to expand Village Medical. In Atlanta, we announced maybe a week or two ago that we've opened our first 4 locations, 5 maybe, in the Atlanta market. We did that largely through practice acquisitions. So we're going to continue to do that. And over time, we'll brand them Village Medical. We're going to open de novo groups because we're going to continue to recruit and employ clinicians. And we're going to oftentimes co-locate them at Walgreens, but that's not all that we're doing. And as Brent pointed out, and why I asked him the question, not even 20% of them that we have today are co-located at Walgreens. Pharmacy and primary care. Dr. Fields once said, when we were talking about this idea of this partnership with Walgreens, Clive once said, if you take the most commonly used service, which is a prescription, with the most commonly used provider, which is primary care, and you co-locate them, you're probably going to get a better clinical outcome. And we've now not only proven that, we've documented it and written a white paper about it. It's available on our website.
Yeah, just that triggered one quick comment for me, Paul, is that it's obvious, I think, to most how pharmacy integration can accelerate when you're co-located at the same site. But we're also going to virtually integrate and do the same clinical pharmacy integration work at sites that don't have a pharmacy. We already do it today, and we'll do things like mail order delivery and MedSync and pharmacist consults and all the elements I talked about at clinical sites that don't have a pharmacy as well.
That's great. I did see one. I was curious because it's around the topic of rural healthcare. And Bruce, if you could ask that question, because certainly applicable as we evaluate new models, especially in our rural areas of Georgia, which I think, like every state, we struggle to really effectively deliver care in some of those markets. Bruce, can you ask that question, please?
Sure, Trent. Rural hospitals are closing at alarming rates. How can Village MD address health issues in the rural areas?
We're excited to move into rural areas. We have rural markets today. So we mentioned, or I mentioned the Western Kentucky market. One of the practices that has come into Village Medical was a former affiliate, PCMC, in Murray, Kentucky. And so that's a lovely community in a rural part of a rural state. And we have additional geographies where we have rural providers. To me, it's about creating access and bringing the data and the integrated technology platform there to help scale the clinical model. And then this is also an area where CMS is really actively working to explore opportunities to bring value-based arrangements for government covered beneficiaries in these sites. So this is an area you can't, in our view, be the most successful at-risk primary care provider in the country without being willing to plant flags in rural areas and bring the same clinical results to patients who live in those communities.
Great. Yeah, thank you for that, Brent. Great question. Certainly applicable to Georgia, as we've seen multiple hospitals over the past several years, especially recently, close in our rural markets. So it's good to see, as we're thinking that through, that there's some solutions with this model. Let me take the next 10 to 15 minutes. Want to open up to any brave souls that are out there. Again, some of the feedback we got from our most recent Lunch and Learns was tremendous topics, great discussions, but want to have a chance to ask questions live and in person. So we're putting all of you on the spot right now to take advantage of this opportunity. You've got two of the greatest minds in healthcare here with us today, and we would love the opportunity for you to get out there and ask a question live and in person.
Okay, I'm going to go first.
All right.
Brent, who's going to win the Super Bowl?
Oh, well, we'll see. I'm kind of hoping Buffalo does. If they can get by Kansas City, I think they win that game.
Trent?
But my
Go
Vikings
Bucks.
are out, so you know.
Yep.
Go
Go Bucks. I've been a Buccaneers fan my whole life, so hopefully return to the tide with Tom.
So here's a little factoid for you. Tim Berry's brother, Butch Berry, you guys that are out there can Google him, was at one point the offensive line coach for the Tampa Bay Buccaneers.
Look at that. Like it. Good fun fact.
Good fun fact.
Fantastic.
Now he's back home with the Packers.
That's right.
Which,
That's
as a
right.
Vikings fan, is hard for me to support.
Absolutely. Absolutely. All right. So Paul's gotten us kicked off with the first live question. How about anybody out there in our membership who has a live question for our panelists? And not all at once.
So there was a question that we skipped over, Trent, and not wanting to shame the audience into asking a question. There was a question about how do we figure out markets? I'm trying to scroll back up here. What are the key determinants before entering a market? And I like the question because we have spent a good amount of time evaluating the top 100 MSAs in the country. And there are, if you looked at the map earlier that we showed, you'll see that we're in Chicago, which is the third largest city in the country, and Houston, which is number 4, and Phoenix, which is probably number 6. And I don't know where Atlanta falls on that spectrum, and then you go to the opposite end. Brent mentioned rural Western Kentucky, and we have a presence in the New Hampshire market, which is for the most part a commuter town to Boston, but a lot of rural parts of the state. So we've got this matrix, if you will, algorithm, if you will, of how we look at a market. And there's certain characteristics that we look for in a market. We like it when the cost of care is high. If you're going to be in the business of delivering value, and value today, for better or for worse, is defined as more cost-efficient care, then when costs of care are high, you have a better opportunity. We like it when there's a good supply of independent physicians. We like it when there's good payer competition. We like it when there's alternative sites of care available so that we can optimize performance. And so we've sort of rank ordered them. And even in our partnership with Walgreens, we've identified, a couple of dozen markets that we're going to be going to because they fit for us and they happen to fit for them. So we've got a pretty good model to actually figure out the places that we're going to go. Georgia happens to have a relatively high cost of care. There have been a lot of people that have come to the greater Atlanta market and risk models, a lot of ACOs that have come and gone by the wayside. WellCare would be an example of that. But we do think that there's a good way to deliver performance in a market like we're in Metro Atlanta market, and other markets in Georgia. So we have a pretty good model for figuring out markets.
That's great. Thank you for that. All right, other questions that are out there? No brave souls. All right. Well, one question that comes to mind for me is, really around, as you identify markets to enter, certainly I know the markets you identified that are top of your list are already very consolidated, very competitive markets. I'm sure that's a component of your analysis, if you will. But the spaces, and especially I've been in the Houston market within the past 5 years with the hospital there, and I know one of the key strategies at the time there was all around urgent care and freestanding ERs. And where do you guys fall within that realm? Is that ever a future part of your business model? Talk a little bit about that, if you don't mind.
So part of I'm a co-located clinics with Walgreens. These clinics are open 7 days a week with extended hours. In our data and in our experience, some of the most successful primary care practices in terms of managing risk are those that just are very highly accessible, right? And so people have confidence that they can be seen the same day if they need to be seen the same day. And so they call their primary care group first. I think in contrast, groups that really struggle with risk, particularly in ED utilization, are ones where they've trained their patients that, you can call the day, but the soonest you're going to get in is a month from now, right? And so they don't even bother calling. They just go to one of these alternative sites. In terms of us delivering that, our core model is to have extended hours with our existing primary care footprint. We will deliver urgent care services, but we're not looking to leverage the fee-for-service price point on those services. But there are markets where we will have urgent care. We're not going to open freestanding emergency departments. The only way that business model works, as you all know, is hospital outpatient department pricing. And it's just not really in our DNA. In fact, we spend a lot of energy trying to make sure our patients understand that we're going to get them in and that they don't need to utilize those types of facilities. But your comments well taken. There's one on every other corner in Houston.
Absolutely. Fantastic. All right, I'm going to pause for a moment. Bruce, any other questions in the queue or any questions from the membership?
I try nothing in the queue at the moment.
Okay. All right. Well, with that said, I'd love to hear some parting words, maybe from both Brent and Paul.
I just have a quick question.
Oh, we got a question. All right, Angela.
So whenever y'all come into the market, y'all described, relationships with hospitals, you've got one with HCA, you've described obviously in detail the relationship with Walgreens. When you come into these markets as kind of a new entrant, this disruptive innovation, that's what we're talking about. Are you looking for specifically practices that are, established, that have a specific patient panel? Are you looking to grow practices, start something from the ground up, or kind of all of them?
So I'll take a crack at that, and then I want to offer just a few color commentary points, and I appreciate the question, Angela. One of the things that we made a conscious decision about at the very beginning when we started the company is that what we were not going to do is what some of the other models are. And some of the other models are go into a market, set up a clinic, recruit a physician to that clinic, and then recruit patients to that physician and clinic. You guys know that, and I know that, you know who they are. that was a business we didn't want to go into. We work with a really nice clinician in Northwest Indiana. He's a Nigerian internal medicine physician. He's there because there's a very significant Nigerian population. He's been serving that community forever. And a company entered that market. I won't say which one. They set up a clinic. They hired a clinician without a panel, and they started recruiting to that clinic. And this particular physician said to me one day, I really dislike this company because they're trying to steal my patients. We didn't want to be those guys. What we said, so there's a few operating imperatives that kind of helped us formulate our business. One was, we didn't invent value-based care. We didn't invent risk. We didn't invent transference to risk. Lots of other people did. We just said, well, if there's going to be a risk model and providers are going to be required to perform, and today the attribution model is to primary care. We didn't come up with that one either. It all already existed. All we said was, we're going to help these guys. We're going to help them, and we're going to perform. And those that actually perform the best should reap the reward, which is shared savings or performance against global capitation, et cetera. That's what we said. And so if you take that as an imperative, we're going to help providers that are already in a community, already serving that community and a patient population. What's Walgreens' tagline? We want to serve our community. We want to serve our neighborhood. They want to be a neighborhood health destination. So what's wrong with all that, right? So that's the business that we chose to enter. One last thing, and I'm not a clinician, but I've spent the last 8 years full-time around clinicians, and before that, a decent amount of time. And the way we think about it, there's a great book. It's the autobiography of Herb Keller, who was the founder of Southwest Airlines. And in that book, he talks about one of his key lieutenants that was working for him and was called by the government of Brazil to go start the Brazilian airline. And he really wanted the job, but he didn't want to bum out Herb Keller by telling him he wanted to leave. So eventually he got up the courage and he said, I want to go pursue this dream. And he said, do you have any words of wisdom for me? And Herb Keller said, yeah, take care of the crew. The crew takes care of the patients. Takes care of the passengers, and the passengers take care of the shareholders. For us, Brent, take care of the clinician. The clinician takes care of the patients, and the patients will take care of our shareholders.
Paul, I was going to tell that story.
Go ahead.
Yeah, no, look, the last thing we want to do, if we're trying to build a culture that's physician-led, physician-governed, and by the way, you don't have to be employed in the group to be part of the governance structure. Our clinical outcomes committee in each market includes our affiliate physician partners as well as Village Medical. You can imagine if our affiliate group felt that we were going after them and their patients with Village Medical, we're not going to be very successful. And so we really think of growth as growing lives that we can be successful with in our value-based contracts. So we're looking at the population where it exists today. We're asking who's taking care of them and how do we bring more of those primary care physicians and other providers who are caring for the population today into the Village model, and then who isn't getting primary care today, and how do we create more convenient, accessible options for patients that just aren't being served today by primary care and are bouncing around to other parts of the care delivery ecosystem. And so we will bring new providers, new to market providers, or providers without panels into Village Medical, but most often, and as you might imagine, some of the physicians we hear from are those that have had a very successful practice, in many cases for decades in a community, and they're looking to retire. They've had a great practice, but they really don't have anybody to hand it off to. And so we certainly have also utilized a strategy of transitioning with those practices. Ideally, that physician continues to work for a period of time, so her patients trust her, that she believes that this partnership makes sense. And then in that scenario, it makes a lot of sense to bring in a physician that doesn't have a panel that can take over that panel for the doc. So yeah, but totally agree with Paul's comments, and that's how we're thinking about it.
Excellent. Well, thank you, Angela, for being the one brave soul. Any parting words from Brent, from Paul as we wrap up today's session?
Yeah, I was going to tell the Southwest Airlines story, but Paul stole it. So I guess I'm out of words. No, I would just say, look, we're very excited about where we sit. We're excited about the opportunity. Frankly, what's most gratifying to me is to hear messages from the physicians that we partner with and other care providers we partner with about the model and the fact that they knew throughout their careers, which has been mostly based in fee-for-service, that there was an opportunity to deliver better outcomes for their patients, but the system just was not designed, nor were the incentives there to do the things that they always knew were possible, but now actually are happening in the Village Medical and Village MD clinical model. That's the most gratifying thing to me. I'm absolutely convinced primary care's best days are in front of her. You know, it's early in this 21st century. And if you think about things in terms of centuries, sometimes it can help put things in perspective. And while we can get frustrated, those of us who have been pushing value-based care aggressively for the better part of the last 20 years can sometimes get frustrated that, boy, there's so much inertia in the system, and is it ever going to happen? If we were having this conversation in 1921, and we were asking ourselves, you know, when will we be able to do more for patients? As we watch people die from acute illness and injury back in 1921. Keep in mind that we would still have been 8 years away from the discovery of penicillin and 21 years away from its first use in humans. And look what we can do now. And so, yes, it's easy to get frustrated from day to day for those of us who really want to see at-risk arrangements succeed because of the better outcomes and better affordability we can create. But we got a lot of game ahead of us in the 21st century, and I think if you're looking back at this 100 years from now, you're going to see this tipping point towards models like the ones we're privileged to be part of. Paul?
If you're working in value-based care, all I could say is keep going. It's hard work, so keep going. Thanks for having us in today. We really appreciate it.
Thank you.
Well, thank you both. Truly impressive work. You know, when I heard we're going to have two disruptors on the call, I'm imagining backwards hats, baseball, you know, bats, but you know, really, you know, exciting work that's happening and work that is changing healthcare. And I think the more that we can work together for the common benefit of the patient, it's a win-win scenario. So certainly appreciate you guys taking the time today to share your thoughts. I will now turn over to Angela to wrap us up.
All right, thank you again to Trent, as well as Brent and Paul. We really appreciate your time today. Thanks also to our programs committee for organizing today's meeting. You did see in the chat box, like I said, I'm chair of programs, Seppi is chair of communications committee. We are looking for new members to join both committees, and both of us put our email addresses out there, so feel free to reach out at any time if you're interested. We'll schedule a quick call, explain what we do, and would love to get you more involved with GAHE. Thank you also again today for our sponsors. We appreciate all that you do to provide leadership for the healthcare industry here in Georgia. Special thanks also to ACHE for hosting today's program so that we can offer you face-to-face credits virtually. Also, as a reminder, please be sure to complete ACHE's meeting evaluation. Your survey feedback will be of great help to us as we strive to have continuous improvement in content for our education committee. Now I'll turn the meeting back to Rico Rivera at ACHE for some closing announcements.
Thank you, Angela. Thank you to our moderator, Trent. Thank you, panelists, and everyone for your participation today. This concludes our session. Again, today's session is worth 1.5 hours of face-to-face education credit and will be applied to your ACG account in approximately 2 weeks from today's session. Please be sure to complete the evaluation by visiting your My ACHE page and selecting My on Learning from the Helpful Link section. From there, click on the Access My Courses link and you'll be directed to the LMS where you can complete the evaluation. The recording for this session will be posted in the LMS within 48 hours of today and will be available to download. Today's program is copyrighted in 2021 by the American College of Healthcare Executives, all rights reserved. Thank you for attending and continue to stay safe, everyone.